The conference would not be possible without our wonderful sponsors. And we'd like to acknowledge the sponsors now at this time.
Thank you very much, everyone, for inviting me and my friends Alfonso and Angie, who are here, international and national experts on topics that you heard this morning. We're going to change gears a little bit this afternoon, I suppose. And it's funny because normally this place is full. It just feels like my voice is echoing. And but at least compared to last year, where it was zero, we're doing much better. Right? So let's see if we can match that theme of resurgence and the rejuvenation of the brain as with rejuvenation of our presence back in person. And let's see what we can do today. I've got a bunch of, as my friend, unfortunate friend Alfonso was saying just now, that we are getting inundated. No, I'm just joking. We're very good friends, actually, and we're inundated with talk. So I literally put this together, unfortunately, yesterday, and so there's lots of slides. And I'll have Shelley tell me when to stop because we've got a panel discussion as well. And when we run out of time, we run out of time. Okay, so this is a sort of a cobbled together presentation, little assortments of things. So let's see, first we can put some perspective of what has not changed in Parkinson's disease despite valiant efforts from people like Dr. Fasano and other members that work really, really hard to try and make the quality of life of our patients who have this illness. But really, even the latest papers still say that this disease is a tough one. Right? This is a tough nut to crack. It affects the patient's quality of life. You can see that 15 years since diagnosis, we've lost a lot of our patients that with Parkinson's disease. Many of them have had falls, cognitive decline, hallucinations, choking. And this is an interesting thing, and I always have these exits that I'm in the middle of talking. But anyway, when I tell my fellows, Parkinson's disease is unique in the sense that it doesn't remain the same. So the definition of Parkinson's disease that we begin with, tremor, stiffness, shuffling, etc., in 5 years, this becomes a different disease. In 8 years, it is a different disease. So if I were to actually present a case to one of my fellows with 8-year Parkinson's disease patient, it doesn't even sound like Parkinson's disease. Look, choking, hallucinations, hypotension, incontinence, etc., etc., etc. These are all symptoms of something else. We were not taught that Parkinson's disease diagnosis includes any of these things, and it doesn't, because at the start, if these symptoms begin at the start of the disease, we don't even call it Parkinson's disease. And that's really the most difficult part of Parkinson's disease, is that the phenotype, or the way a person looks with this illness, changes every few years, maybe every year in the brain, or every an hour in the brain. We can't measure that. And so the interventions that we do at year 1 are different at year 5, have to be different at year 10, and may not be applicable at all by the time year 15 occurs. And that's the bane of our existence. We cannot say that, let's do stem cell transplant, but in whom, when, at what stage, what age. All of these things matter. And the same thing happens with focused ultrasound. We have to be able to have a consistent phenotype, and that's exactly what this disease is not, right? And so 20 years since diagnosis, just 5 years, look what's happened. Everything has changed. So in these patients, 80% now have dysarthria, 50% have choking, almost 100% are falling. Dementia is in 85, 90%. This wasn't the case at year 5. This is a different disease, right? And so the disease, unlike diabetes is, yes, it affects other organs, but it's still insulin, diabetes, and et cetera, right? And that's the difficulty even with epilepsy management is much simpler, because epilepsy is epilepsy. It continues, the same disease doesn't change. Here, the very construct of the disease modifies itself over time, and intervention becomes exceedingly difficult. And that's why we've had a really tough time trying to make or break into this particular illness, is because we don't understand it at the start to begin with, and what happens to the brain over time. There are so many exits off of this, as you can see, that each patient's profile becomes dramatically different, and that makes it very, very challenging for us to come up with interventions that are consistent. Levodopa has done that for us, right? Levodopa is the universal drug. There's no chance that surgery or transplantation or anything is going to make any such interventional difference to our patients with Parkinson's disease. There's zero chance. It will not meet that criteria that levodopa did, which revolutionized the treatment of Parkinson's disease for everyone, right? And that's what insulin did for diabetes. Unfortunately, we haven't got such a therapy. So what are we going to do? Well, I mean, I'm going to go through a little bunch of vignettes of, as I said, update on selected topics of where we are. You know, obviously the hot stuff is what people get attached to, intervention, right? That's what's on television. We don't usually have neurologists prescribing levodopa that gets onto mainstream NBC, but you have surgeons opening brains and taking things out and putting in, that's what gets on television. And at the same time, it's important to put that in perspective in where we are at. There are lots of positive things going on, but at the same time, there are lots of challenges for these television-style therapies, and I wanted to put that perspective here, right? So disease-modifying therapies, for sure, we want to change the course of the illness. The disease changes itself, as I told you. It's not something that we have even any control over. So we want to try and do that to see, can we keep that phenotype of the year 1, year 2, year 3 patient and keep them at year 30 looking the same? Let's see if we can do that. At the moment, that's not possible. So the idea is to try and change course of the disease, and we can target things such as genes and proteins that have been sort of revealing a little bit about the understanding. Maybe this is a particular gene that we can modify. Maybe there's a protein product that we can change. Right? For example, alpha-synuclein gene is a particular protein, alpha-synuclein, the gene that makes, and we'll go into a little bit of that as to how we could do this, how people are trying to do this. There's another enzyme called glucocerebrosidase. It codes for a well-known disease called Gaucher's disease. Not Parkinson's patients don't have Gaucher's disease, but there's some linkage between this potential gene and risk for Parkinson's disease. Can we change that? Is it possible? And we've got a trial, as many of you may know, maybe have participated, that we are doing in London. We just finished enrollment yesterday, actually. Or whether, you know, we can change cell death itself. So far, everything that we have in this field has remained experimental. So let's start with this alpha-synuclein, right? So reducing its synthesis by doing something called ASO. ASO stands for Antisense oligonucleotide. This is a big word. It's been in the press lately for Huntington disease, for example, and the protein Huntington. Well, what is an oligonucleotide? An oligonucleotide, the big word oligonucleotide, we won't go into exactly what it is, the details of the definition of the word, but it's a synthetic polypeptide. It's a synthetic thing that's made, which binds against a particular section of DNA or RNA, and it silences itself. So silences the other thing. So let's say there's a gene abnormality in an alpha-synuclein that produces a product called mRNA, and that, of course, is in the literature now everywhere in public because of this silly virus confusion that people have had with vaccine, that mRNA is a new discovery. This is not true, as you know very well. And so mRNA makes protein. And so if we can actually come up with an antisense against the sense of that mRNA for alpha-synuclein, we could neutralize that. Well, that was recently attempted very valiantly in Huntington disease, and unfortunately that trial failed, as some of you might know, to a great disappointment for many people, including us. So there are mixed results with this antisense oligonucleotide, mainly because we don't really know how much to reduce that alpha-synuclein, right? So, and that was one of the things against this ASO for Huntington disease. It wasn't specific for the mutated Huntington. It was generally for Huntington protein. Again, there's a difficulty in coming up with a specific antisense oligonucleotide for general Parkinson's disease. It may be against a particular gene that we might want to come up with, or alpha-synuclein may not be bad at all, right? And so the current evidence of using antisense oligonucleotides for Parkinson's alpha-synuclein protein is a construct that has lots of controversy built into whether we will actually ever see. Some of us don't even believe that alpha-synuclein does anything at all, that it's an innocent bystander, so reducing it may not mean anything at all to the disease itself, right? Another construct, for example, is beta-2 receptor agonists, so drugs that we use for treatment of asthma, you know, those puffers, reduce the expression of alpha-synuclein, but at the moment, large epidemiological studies didn't show up much in terms of use of agonists or antagonists, so using, you know, these agents to reduce brain alpha-synuclein. This is epidemiological. This is not actually based in animal models, although animal models had shown that there was some effect of changing the beta receptor function and expression of this alpha-synuclein, which means access to the brain tissue is also very difficult for us to get with external drugs. The second concept may be not reducing synthesis, but increasing clearance, right? So at the moment, this is in the experimental and animal stage. So we give drugs that ask the protein to be released faster. Well, neurons do this anyway. They excrete proteins all the time. And one of the ideas of spread of Parkinson's disease in the brain has been, and I have lots of doubts about this prion-like hypothesis where protein spreads into tissues. This is also, I think, incomplete science to say that disease spreads inside the brain by protein excretion from one neuron to the other. Lots of interesting animal data is there. There's animal models for this as well. But we don't have anything to increase the clearance at the moment of this particular product. So alpha-synuclein, which is the flagship hallmark protein problem in Parkinson's disease. Well, again, another recent study is this, I wanted to bring this up because, these are difficult drugs to use. Nilotinib, which is not a new data set for us, but it's in the last couple of years. So in terms of binding and removing alpha-synuclein, the antisense oligonucleotide, increasing clearance by giving medicines that will deposit out of the CNS this particular protein, and then trying to change the third concept in this is that alpha-synuclein, which is this protein, as you accumulate more and more and more, it starts changing the structure of the alpha-synuclein. So let's give you an example. Let's say that all of you had this cannoli-style dessert. If I have a small box and I can put 3 of them in one, well, that's good. It looks good. If I say, there's actually, I like this, I'm going to take somebody else's 5 more, and I stuff them in there, and I stuff more in the box, guess what happens to that cannoli? It starts becoming squished and mushed and folds itself. So when you take it out and take it home and open it, it kind of doesn't look like what it looked like on the dish. So this is misfolding, aggregation. This kind of stuff can happen within that box, right? So can we change the misfolding and aggregation to make it so that the rope is not into coils or the alpha-synuclein is not structurally abnormal? Can we keep it normal? Maybe that's why we have toxicity on the neuron. So we have a way of trying to do this. Well, this particular thing called ABL protein, the tyrosine protein kinase. So tyrosine is the mother molecule from which dopamine is made, which is something different. But this tyrosine protein kinase ABL protein inhibitor is actually something that is used in treatment of leukemia, so CML, right? So very well understood, well treated CML with this particular, and leukemias in general, chronic myelogenous leukemia. And the reason that this became interesting is because ABL activation can lead to cell death, and nilotinib is already approved by the FDA as an inhibitor of this protein ABL. So hey, look, can we now do inhibition of this particular protein, which then inhibits cell death, et cetera? So nilotinib has been used. There was a phase 2 study, short-term and long-term safety for this product, and it shows that it enters the CSF, which is into the brain systems. Maybe it has some effect. Lots of controversy in this particular big paper was published a few years ago. None of us are recommending that people go on chemotherapy, which is what this is, right? It's chemotherapy for cancer and all the issues that patients with Parkinson's disease will face with respect to using nilotinib for treatment of Parkinson's disease, which itself is a difficult disease, right? So an efficacy has not yet been demonstrated because, as I said, the drug is chemotherapy. Again, a perspective. See how difficult it is. You've got these nucleotides you've got to get into the brain against the protein. Folding of this protein to be affected. This is not easy stuff to be able to do, right? And so, but it's out there, right? There's also another, I'm not particularly familiar with the latest literature on this, but this is there in my read, a drug called squalene, which has been looked at. Again, this is the current, maybe Alfonso knows a little bit more about this than I do, because I've not come across any studies of this across my read, but I didn't actively look. The next approach would be to use immunization. We're all now familiar with all these vaccines, et cetera, which is not a new science, has been there for hundreds of years. Same thing that we are doing today for COVID. Immunization in which way? Well, there are different ways to immunize, right? So antibodies against alpha-synuclein. So directly, you take antibodies that are synthetically made, you give it into the patient, and it now neutralizes, binds, stops production, et cetera. Not the actual mRNA that we were talking about or DNA with the antisense oligonucleotide. This is actually directly an antibody against alpha-synuclein. A phase 1 study has been done. It shows that it's safe. There's actually phase 2 ongoing. Unfortunately, I'll say that in other diseases like Alzheimer's disease, these kinds of antibodies have not worked. In fact, have produced toxicity more than anything else. So we'll have to see what the data shows in terms of alpha-synuclein antibodies. Then the other way of immunizing, which is a standard way, you actually take the protein, small pieces of it, and give it, right? And so if you were to take pieces of the virus, for example, or some other such thing which we immunize against, let's say polio virus, and you give attenuated portions of the protein, then the body generates antibodies. So these are not externally given antibodies against alpha-synuclein. This would be immunization. So you give 1-2 shots like we're doing for this flu bug, and you generate the antibodies against it. So it's autoantibodies. So actual pieces of protein to develop antibodies, and then synthetic alpha-synuclein pieces, right, to immunize. So go and indirectly work against the alpha-synuclein and immunize against the alpha-synuclein. So these are all ways that people are doing these studies at the moment. And whether, obviously, this would be something that would be very nicely applicable to the public, right? Because you could, unlike brain surgery, which is only in a small % of people, or using other techniques that are transplantation only in small groups of patients. Immunization could be done, as we're doing now, in a huge number of people, potentially even preventative, right? And so that's why there's a lot of interest in pursuing these kinds of approaches for this protein, alpha-synuclein. So a very brief overview of how this protein-related, either removing the misaggregated protein or immunizing against it or giving actual material to neutralize production, all of these are approaches that are hot at the moment, and there have been for some time, and people have been working on this to be able to have a modification of the disease as compared to our treatment. So for example, even focused ultrasound or DBS that we've been doing all these years, that it doesn't change the course of the illness. All of those things, that's why I gave you that perspective. All of those things that are there in that list at the first and second slide, they don't change with any of the interventions that we currently have. People are still going to fall, they get demented with Parkinson's disease, choking, dysarthria, all those things that happen. None of our therapies change the course of that illness, and that's what the concept of what I'm talking about now is all about, changing that so that 15 and 20-year thing doesn't happen, or doesn't happen for even longer, right? These two genes that I talked about, well, there's a little bit of work that's being done on this. So this LRRK2 gene, which we won't go into details of what it sounds like, the full form of it, lung, and it is the most common genetic relationship to typical Parkinson's disease, right? So typical late onset, our usual tremor, asymmetry, stiffness, shuffling, etc., right? And so far, no successful treatment option for treatment of LRRK2 has come about. And the difficulty with gene kind of problems is that we need to be able to demonstrate in the animal model that this particular gene, even though it's present in human, in Parkinson's disease in some patients, that it actually can cause Parkinson's disease in the animal model. And we tried in my lab to come up with an animal model, and unfortunately, even though we were able to get the animals to have the genetic abnormality, they never developed any Parkinsonism at all. So it's obviously species are different, and so we couldn't make that model, hence treatment against this in the animal model has been very difficult. Glucocerebrosidase, which is an interesting thing. And the reason it's interesting is that it is probably one of the biggest risk factors for Parkinson's-like syndrome to develop, right? So low activity of this particular enzyme called glucocerebrosidase, as I said, there's a disease called Gaucher's disease, which occurs when you have significant and pediatric disease, but it can actually also occur in adulthood as a disease itself, has been linked to Parkinson's disease. Down syndrome and Alzheimer's disease, for example, have a linkage in terms of early development of dementia. And interestingly enough, there's an exceedingly complicated and expensive drug, which actually just a cough syrup you can buy over the counter, called Ambroxol, right? And some of you may have even participated in our study. We've just finished, as I say, the enrollment. One of my brilliant colleagues, Steve Pasternak, and I have a grant to do this project for using this cough syrup. Funnily enough, even though the cough syrup is available over the counter in England, we couldn't get it in Canada, so we had to spend enormous amounts of money to get, and literally, I'm not joking, to get this cough syrup imported from England. And so that study just finished its enrollment. And the idea behind this is to increase glucocerebrosidase activity. Now, we couldn't do this study in terms of treatment of typical Parkinson's disease motor symptoms because it would take too long. So what we did was to be able to meet the requirements of the grant. We've done this in patients with cognition, and I have huge doubts as to what we will see because it's only a 1-year study. That's all we got the funding for. But anyway, that's what it is, and so we've actually demonstrated, it's been published already a couple of years ago, that using Ambroxol, we can increase the penetration, and in fact, we can measure the levels of glucocerebrosidase. I will not tell you that data at the moment because it's under analysis, and it's safe. It penetrates the brain and increases the levels of glucocerebrosidase. Again, as I say, the details I'm not going to go into at the moment. Obviously, who cares if it increases the glucocerebrosidase if it doesn't actually change cognition in patients? We got to wait for that because that enrollment just finished. So we will see. I mean, again, the idea is that, hey, it's cough syrup, right? You can just give it to anybody. You can buy it at shoppers if worse comes to worse. We don't have it, obviously, yet. But so this is the idea of how we can either target the gene directly, which we haven't yet, or attach something to an already known repurposed product that increases an enzyme, maybe that then targets the gene, et cetera. So this is what is there in the other genes. Well, we talked about modifying the product. We talked about modifying, but there's actual gene therapy itself, right? So this is not pathological genes now. This is not the LRRK2 or glucocerebrosidase gene. This is actually giving genes. So this is different. Right? So not blocking the protein, not blocking the gene, but actually giving the genes themselves. And this obviously is, again, cutting edge, very interesting bench work. How do you deliver it? Well, you use viruses. So same virus that we've been paranoid about and afraid in the last 2 years across the planet. Well, we use not the same virus, but such viral vectors. You can imagine how recruitment may be difficult now all of a sudden given where we're at, to say that we're actually going to give you a virus. Guess what? Maybe that's not a good selling point in the consent form. But at the same time, but anyway, so replacing genes, that is the only way we know. And the reason we know this is because viruses are really efficient at doing exactly that, taking genomes, small genomes that they have, or anything else that you stick into the virus, and incorporating that into your own genetics. So they're really good at doing this. We won't go into the enzymes that they have, but they have enzymes to do exactly that. And that's really cool, because you can go and glue in some other gene. There's a problem, of course, is that maybe it's not targeted specifically to a particular area necessarily unless you deliver it to the target, right? You can't just give it IV. That's tough stuff to do, right? So generally, these viruses have been safe and have been used for other diseases, and there are some approved therapies as well and that kind of thing. And we can do this to specific areas of the brain if all goes well. Again, as I say, just like the ASO we talked about 5 slides ago, the quantity of delivery is very difficult to control. And once you get it in there, it's not reversible, right? And so the same thing, like as I was saying to Dr. Fasano, I'm not a huge fan of going back to doing lesion surgery in the brain. Main reason for that is not reversible, right? I mean, we went away from that for that reason. And so, and that's a controversy debate we can have at our, but the same thing here. Once you deliver the virus, you deliver the gene, you can't go and say, oh, shoot, can I have 50% of that back again? I mean, there's no, vacuum cleaner there to go and remove it. So this is the problem with aggressive therapies, and so we have to make sure that they are real safe, that at worst they don't do anything. Okay, that's fine, right? But at least we don't want that to develop into a mutation into the genome that causes, let's say, cancer development. And these are all risks that are there. And there are many different kinds of ways of getting these gene therapies in there. Aromatic acid decarboxylase. Aromatic acid decarboxylase is actually an enzyme that is in our bodies, and it's present in metabolizing and making dopamine, right? So if we can give aromatic acid decarboxylase to tissue and make, so one of the problems that happens, as we know very well, Parkinson's is not a single area that is affected by any means, but the dopaminergic neurons, which have this particular enzyme, aromatic acid, right? So benzene ring compound, which makes into dopamine decarboxylase. If we give AADC, you can make dopamine from levodopa, tyrosine, and that cascade in that pathway. So one way would be to give this particular gene. Right, so there's also a gene vector product called Pro7, and it's a viral vector with 3 enzymes. We won't go into the enzymes, it doesn't matter. But instead of giving one enzyme, you give multiple enzymes. So now you've got appetizer, main course, dessert, coffee, all part of that package. Everything is given. You don't have to go to different places to get this. So instead of having one enzymatic therapy for gene, you give all these genes. So then the neuron becomes safe, fully functional with all the machinery that you need, right? And so there's a study, OXB 102, that's ongoing, and safety has been established. We are waiting for the results of that particular study to see whether there's, in fact, so a lot of these particular therapies, you can see the theme, safety established. Yes, it works to getting into the brain, but does it do anything? Well, we've got to wait for that, and that's obviously where the biggest conclusion is, because, you know, nothing comes from nothing, right? So if it gets in there, does nothing, well, then there's nothing. So it doesn't matter if it's safe, but sitting in the car not driving is really safe, but then, you know, you don't get anywhere. And so that we don't want that kind of a therapy, isn't it? And so the next is directly basal ganglia modification. Basal ganglia are actually basal nuclei, a bunch of neurons, you know, millions and millions of neurons, where deep in the brain we have pathology that occurs in Parkinson's disease related to the function of these areas. So we have adeno-associated virus, GAD therapy, another, doesn't matter. I'm just listing them off in terms of, you know, telling you where the science is, update on this kind of intervention, disease modification. Years ago, and in fact, even early days of my career, the 2 particular products, glial-derived neurotrophic factor, GDNF, and nurturin were 2 of these let's get the neurons to grow kind of thing, I mean, simplistically speaking. And unfortunately, both of those studies didn't show particularly any change at all, and they were stopped early because of the fact that it didn't show. But those are early days. Now we've got better and better targeted techniques. Let's hope that. See, the thing here is that people are trying to look at both specific to a very complicated therapy for a few patients, all the way to using a more generic therapy that can be useful for the populations, like immunizations, like, this would be very difficult. You have to actually inject into structures in the brain. So very targeted therapy for some people, whereas immunization and giving, you know, things that can be given IV, not into the spinal cord, are for general Parkinson's disease treatment. So both of those flavors I wanted to give with this kind of therapy. Now, another theory, so we talked about the protein, we talked about genes. Another theory that has been batted about for 50 years in Parkinson's, nothing new here in terms of the theory, is that there's inflammation going on. Well, the brain is a very protected environment, right? And there's a very special type of cell line that we have in our brain, glial cell line, related to inflammation that occurs in the brain. And we see in pathology that there's activation of these, what would be, you know, white blood cells in the periphery. If I were to get sepsis and you go to the emerge or ICU, we'll take your blood, do cultures, and we'll see that your white cell count has spiked maybe 25,000, and say, my God, the person has got a huge infection going on. Well, in the brain, we don't have such measures. It's not possible for us to say, oh, look, in Parkinson's disease, we're going to do a lumbar puncture and see we've got all this inflammation. It doesn't seem to happen, right? However, in tissue, locally, in pathology specimens and autopsy specimens, you see that there may be this inflammation. It's always been a chicken and an egg story. Is the inflammation causing the disease, or is there degeneration of neurons that then asks for cells to come and mop up? So after all of this is done, there'll be lots of dishes and dirt and garbage and all that has to be done. So people will come in and take care of that. Well, they're here to help afterwards. Or are they here to make the mess? 2 different constructs, right? Because if they're here causing harm, we can say, wait a minute, doors are closed, right? But if they're here to help, we don't want to do that. And that's always been the controversy with neuroinflammation. MS, for example, multiple sclerosis, is a very for a flagship inflammatory disease. So we use anti-inflammatories, many new drugs, most of the drugs I can't even pronounce, natalizumab, rituximab, this mab, that mab, these kind of things, which are used for treatment of inflammation that occurs IV in patients, including in the CSF, to reduce the inflammation. Well, in Parkinson's disease, this has remained controversial. And yet, years ago, again, I said in the early days of my career, there was a clinical trial that the FDA, the Americans were going to be doing. We were going to participate using Celebrex celecoxib, to try and reduce inflammation in the brain. Never went anywhere. There was lots of data with this kind of thing. Well, maybe even simple anti-inflammatories. Intriguing data that using indomethacin, ibuprofen-like drugs has an impact on patients' development of Parkinson's disease. Again, whether we actively intervene with these drugs, well, there are lots of side effects, right? So recently you might have heard that the FDA has removed the recommendation of using baby aspirin for people that don't have known cardiovascular disease already. So as prophylactic, use of aspirin is bad because it increases hemorrhage risk. So that's been eliminated now. Recent paper that came out in the American Heart Journal. So same kind of a thing, right? So we want to be able to use intervention that doesn't cause harm, right? So that's why those anti-inflammatory drugs chronically, not necessarily good for your GI systems. PPIs are drugs that we use like Dexilant and for treatment of gastritis. Also, chronic usage of that changes the chemistry of the stomach, and maybe that has something to do with Parkinson's disease and its effect on absorption of drug, for example. Big thing in our world in terms of patients that fluctuate. So reducing inflammation using this particular thing, GLP-1 agonist exenatide, right? And so there are other drugs in this class that are being tested. Early data shows maybe some positivity in reducing inflammation progression. Early days of this class of treatment. I briefly gave you the anti-inflammatory thing, but none of us are prescribing regularly any anti-inflammatories for patients with Parkinson's disease because of the risks that we have. Right. There are a couple of other agents that have been talked about. There's a drug called Pioglitazone, which is shown to increase mitochondrial genesis. Well, what is all that about? Well, again, for 30, 40, 50 years, there's been a big linkage of mitochondria, which are the energy-making bacteria, actually, that are inside every one of our cells that make ATP, right? And they are required for life. You don't have mitochondria, you're dead. And so the idea that in Parkinson's disease, there's a problem with mitochondrial function. Well, can we increase the mitochondrial function? There's lots of work being done using coenzyme Q, which didn't work as an example, right? And creatine and those kinds of things that are energy-producing things, right? So just because you can get to the health store and buy a big jug of creatine doesn't actually mean the cells will use it. In fact, it doesn't use it. That's what we've seen. However, the construct still remains, and mitochondrial function is clearly abnormal in patients with Parkinson's disease. And we have a very large study that we're doing that we're recruiting. We have a large grant from the Research Council of Norway with my colleague in Bergen, Harris Sulis, and I. 30 million euro grant that we have to recruit 2,000 patients. We're recruiting actively, doing many things, including muscle biopsies. And Harris's specialty, Charalampos Sulis is his name, and Harris, very bright young man whose expertise is in doing very fine mitochondrial work. So we're sending the biopsies to him. Again, the idea being that maybe there's a mitochondrial thing that we can. And in this particular drug, part of this NET-PD study, unfortunately, didn't work, but may not be targeted. Recent study with another particular compound, urate, right? So uric acid elevation, Parkinson's disease. So the idea is that higher the uric acid, there was an epidemiological association. Uric acid, you might know, causes gout, right? And so we obviously didn't want to replace patients with Parkinson's disease now getting gout. So the idea was that if we increase uric acid, maybe that would help. And this particular study called SURE-PD was unfortunately negative. So increasing uric acid didn't really do very much in terms of the therapeutics of Parkinson's disease. Long term, who knows? There are, interesting again, iron. These are all old guys, right? I mean, when I was a fellow previous century, we were at that time talking about mitochondria and iron and Parkinson's and those kind of things. But there is a large European chelation study called FAIRPARK-2, where trying to reduce iron. And one of my senior fellows, Dr. Soumya Sharma, has done quite a bit of work looking at very fascinating ways of imaging iron, new techniques that have been developed, looking at this. Whether iron is a bystander, well, who knows in terms of toxicity. Iron is an extremely brittle element that unfortunately during evolution was the best available to us because it's the most abundant such compound, because it can give and take electrons very quickly, ferrous, ferric, and that change in ferrous to ferric and back again is a very efficient energy producing system. Right, so it is, as I say, it's the fifth most abundant element outside of oxygen and carbon on the planet, and it is the most abundant on the Earth's mantle. Right, so that's why iron is part of our heme molecule. It's critical for life. Iron is present in all of these redox reactions, but it is a razor's edge. So something goes wrong with this and it can cause accumulation, and we have diseases with iron accumulation that occur in neurology that can produce Parkinsonism. And it's friend or foe. It depends on which way the gun is pointed. So given this kind of approach, chelation for iron, which is accumulated in tissues in Parkinson's disease, has been talked about for a long time. And most of us don't do chelation therapy, and I'd love to hear Dr. Fasano's opinion on this as well, because deferriprone, which is the drug that's used, and this study is using this particular drug, boy, it has problems in terms of other toxicities that the drug can cause. But I wanted to bring it to your attention as the old guys being resurrected again, iron chelation, big study in Europe going on at the moment. Right, and then finally, of course, in that same vein of things, not final slide by any means, and again, tell me when to stop, please. Cellular therapies and stem cell therapies, and Alfonso was just telling me that they are doing this study in Toronto recruitment. We don't do those little things here in London. We only do big, So stem cell therapies again, old stuff being resurrected. But with new techniques, you never know. I mean, it's possible for us to be able to. So mesencephalic, which is, brain stem mesencephalon, meaning midbrain. Fetal cell transplants have been done a long, long time, before even I was a neurology resident. Direct grafting of cells, currently generally not being done. I mean, it's a difficult thing, right, to be able to. See, the problem with Parkinson's disease, that's why I showed you those first two slides, right? This has nothing to do with dopamine, right? Those things that I showed you, the falls, the dementia, the difficulty with swallowing, the dysarthria, hallucinations, etc. This is not a disease that's isolated to the substantia nigra, which you might hear, the nigrostriatal system. This is not a disease that is, it's actually a multi-system disease. You get constipation from the disease, right? You get all these other things that occur. So this is not a single place that you can go and put tissue. That's why I disagree with having to put, because it's possible, for one thing, it's an extremely targeted and difficult therapy for a disease that is everywhere. Right? And so it's got all these tables, and we're going to go and treat that one. And that's a difficult thing, to understand in my mind as to how we're going to produce that effect. Science behind it is not good to be able to say that we understand the connectivity of all these systems in the brain, to be able to be so reliable in our intervention, which is tough stuff for a scientist to accept. And so I have trouble with that. But in any case, I think, we need to move forward. Clinical equipoise, scientific equipoise, which means that you need to really, before you intervene, one of my dear friends and mentors for me, Ira Scholzen, always stood on podiums at the Parkinson study group and says, equipoise. And to have equipoise, we have to be careful before we intervene, before we jump, that do we understand enough? And there's a risk with this, right? And the reason there's a risk with this is that if you go ahead without that equipoise and the trial fails, it is unlikely, because people like Alfonso and I don't have any money. We can't do $100 million, $200 million trials. It's not from us. It comes from companies that really are on the stock market. They need to be able to show that this intervention is going to produce something real that will translate into therapy, but also not cost enormous amounts of money. And if one company does this too early fails, the other companies may not participate in putting their 500 million into development of therapy. So there's a an aspect of it that's important there. So these induced pluripotent stem cells are these reprogrammed skin blood cells. So we actually can do the mesencephalic transplant. You can take cells that are from fetuses, right? Or you can reprogram cells. And the advantage of that is that these cells are taken from the patient. Right? They're taken from the patient, programmed, so immune reaction and rejection potential is clearly less. So there are 3 studies going on, and I didn't know the study in Toronto. It's not listed on clinicaltrials.gov. I couldn't find it, at least. And I say I did this yesterday, so maybe I missed that. And it's a Toronto study. I probably ignored it anyway. And so, European STEM PD study, right? So 2 studies. And Alfonso, I mean, really, obviously, since you're probably up on this stuff. We don't do this here in London. But, 2 studies called Transneuro with fetal cells and this neurostem cell repair with human cells that are pluripotent cells that are being used. And then there's the New York study, which I do know about because they've contacted me about this study. And there's a study in Japan called the Sierra study in Kyoto, which is using these induced pluripotent stem cells. So resurrection, it kind of died over the last 15, 20 years. And the reason for that is that these transplants produce lots of complications in terms of producing runaway dyskinesias. Some of these people ended up having to go and have DBS because of the complication, and outcomes weren't that great. Some people did well, so it's all over the place. And now I think probably these consortia hopefully are doing a much more organized, and again, a very limited number of people are going to get stem cell therapy done into their brain, right? This is not something that's happening at your neighborhood Walmart. So, and the reason I don't do it, jokes apart, is that it requires an enormous infrastructure to be able to do this. As many of you know, largely I'm the only one that runs the show here in Southern Ontario for Movement Resource Center. We're too busy to be able to handle such a complicated study and Toronto has the infrastructure to be able to do this, and definitely if we have patients, even though they're going to go to Dr. Fasano, I will send them the patients, right, Alfonso? Just make sure that you take good care of my patients, and then there are lots of open label studies going on, and all the time we'll get asked by people saying, oh, there's somebody's doing this in Tucson, can you send me there? I'm not sending people there. That's not happening, right? And so this is I wouldn't say dangerous, but this has to be done in good hands. And I would only send somebody like that to Alfonso, because I trust that there's going to be all the due diligence that's going to be done to take care of my patients, right? And so this is tough stuff, right? This is not easy. Huge problems, huge problems. I have, lots of doubt about not the diligence, but the science underneath for this. So it is revolutionary, but with a lot of care, right? So that was the topology of where we are with proteins and genes and these kind of things. But I just wanted to cover a little bit about some of the newer things that we are actually using in the clinic that we can do. I have lots of other stuff that we do. We're not going to talk about some of the really cool things, such as spinal cord stimulation that you've heard that we do in our lab, and a new device we've built in the lab to do non-invasive stimulation, but again, it's in research mode. I didn't want to talk about our work here today, and we're actively enrolling for this, where we're doing some fancy multi-channel EEGs and all that kind of stuff that the guys in the lab are doing. But directly in terms of treatment. So DBS, duodopa pump, we're not going to talk about. That's old news in terms of you've heard it many times. Safinamide is a monoamine oxidase inhibitor that is on the market. It has some properties to help with dyskinesia and wearing off. So we are using it here and there. Nothing new there in terms of advance. The one that I do want to talk a little bit about, and I'm going to spend a little bit of time if we have any time. We have any time? Okay, on a drug called Apomorphine, and one of the main reasons I want to talk about this is that it's not a new drug. Again, Alfonso has used this in Italy for a long time, and including Apomorphine pump, which we won't have in Canada, I think, if at all, for a little while. But this is not morphine, and that's one of the main reasons I wanted to bring this up, is because it's not an opioid. It is one of the most potent dopamine agonists that we have. It's a D1, D2 dopamine agonist, just like dopamine itself, and it's fantastic, actually, if, again, used in targeted patients. There are two versions of it. I'm going to first talk about quickly the subcutaneous injection of apomorphine, and it's a EpiPen-like pen. I'll show you the picture. It was approved in 1993, right, the year I graduated out of neurology. And so long after Alfonso, I mean, but certainly, that's why you've been using it for so long, and so. And 2004 in the U.S. Well, you can just tell from the hair. I mean, and so subcutaneous apomorphine indication is acute intermittent treatment. So intermittent for hypomobility. So these are patients who are going to get stuck getting out of the chair right here, right? And within 5 minutes, 3 to 4 minutes, give yourself an injection. Up you go, and it's that good. And we've had patients that we've now done numerous in our clinic. It's only been available a little while, and Alfonso will agree with me. As I say, he's got a lot more experience because he's used it a lot longer before even coming to Canada many years ago. And I like it as adjunct therapy, and I'm actually expanding the boundaries of how I'm using this particular product. Quick improvement, 4 to 10 minutes, and it's short. It lasts 40, 30, 50 minutes, an hour. And you can imagine that somebody's in the mall, you're grocery shopping, something like this, and then there's a sudden off, or the off occurs, and now by the time you take your levodopa by mouth, it's going to be 40 minutes before you turn on. This is an injection you take, and in 5-10 minutes, you're out in the car and driving home and able to function, right? So this is the kind of pen that it contains 30 milligrams and 3 milliliters of apomorphine, right? You discard each pen after 48 hours of use. So it's got about 4 or 5 clicks that you can use. And needles for injection that to be changed. So there are some technical problems. Obviously, if you're off and you're stiff and you're not able to get the needle on, then you can't get the needle on. And you can't keep the needle on and just hang around with a needle in your pocket. It's not possible to do. So there are some practical things. And, I do find that pharma company people, marketing people don't understand what the disease is and say, well, what do you mean the person? I said, the whole reason we're giving this is because somebody's turned off and they've got a tremor like this. You're trying to get a syringe and a needle. Who's the idiot that thought that everybody could use this, right? And so this is, again, a practical issue. We have to screen people as to who would be able to use this product, not those people that are clearly not going to be able to. So there's a caregiver requirement in some. There's also a problem with the drug in the sense that it causes a lot of side effects. It causes a lot of hypotension. I actually was using this with Dr. Lang, who's my mentor in Toronto, and under whose guidance I trained many years ago. And at that time, apomorphine was available through Health Canada for intraoperative use, for testing in the OR, but we were also using it outside just as a testing. It wasn't available like this for use. And boy, these people, you'd get sick, right? Because apomorphine is extremely nauseating, drops blood pressure. So what do? We actually have to, so this is actually just a technique as to how to do it. I just wanted to show, pictures to, and it actually does. There's no question it works really well. And so it is certainly a thing that we have in our doctor's bag now, and I'm very, very happy to have this because we had nothing that had patients being able to go from an off to an on state quickly. And so, so here are all the injection sites you can use. It does cause nodules and things like this. Apomorphine has been tried in various different ways, intranasal, et cetera, and it was IV, very bad. You can't use these things. Pumps also, there's a problem because after a little while, the pumps become localized. But again, Alfonso has more experience with this. I have zero, actually, with the pump. We don't have it here, right? So it's, again, intermittent. It's an adjunct to oral medicine. You would never use apomorphine as monotherapy in people. So you're not going to take a patient that is newly diagnosed and give them apomorphine injections, right? And it's individualized. And the reason it's individualized is that, not just the reason, and the necessity is that you have to do it in clinic. We have to bring the patient in and monitor their blood pressure, monitor their nausea, and you have to pre-medicate patients before they get apomorphine with domperidone, which is an anti-nauseant, for at least 3 days. And so we would prescribe this by giving domperidone for 3 days. Then we bring the person to our lab, and then we titrate them. So, and it's a tedious procedure, because if you have to give 2 milligrams first and see what happens if they turn on, and then you've got to wait 2 hours before you give the next dose. So you can't bring somebody at 1 in the afternoon, because then, you're having your late evening snack together, which is not good, because that takes you into the end of the day. So you have to bring them in the morning. You have to bring somebody off drug in the morning, although I'm not a big fan of that personally in patients like this, but you can. We do it all the time. So you have to have somebody that comes without being on levodopa first thing, because if they already are on, then we have to wait till they turn off to see what the effect of the drug is, right? Because that's the whole point, is to be able to see how much to give in the off state. You don't want to give the drug in the on state, because then you don't know that it did anything, right? And so that means that the person comes to the clinic without having taken anything overnight, which we do all the time, and that's not a difficult thing. We do 4 or 5 patients like this these days every week, actually. Not with apomorphine, but for lots of other research studies and things that we're doing. And then once the person comes in off, and we measure their off, we give this injection, see what happens to their on, and determine whether 2 milligrams or 4 milligrams is their stable dose. And then we send home all the equipment with basically the pen and tips and that kind of a thing, with their dose as being their 4 milligram dose, right? And so then, but they have to be medicated to avoid the nausea, right? So there are 5 injections per day, total of less than 20 milligrams, even though there's 30 milligrams in the vial, right? So you got to select the right patient. So hypersensitivity to obviously apomorphine and some other contraindications there, but we do a cardiogram on everybody as well. So there's a procedure involved, but it's not that onerous, except in the last year and a half, believe it or not, it's been impossible to get family physicians outside to do cardiograms because nobody's working. And so we have to get the person to come in to have a cardiogram, which has been a nightmare to bring into the hospital. So it's been a coordination problem to get some of the pre-work done. But we've done about 8-10 patients so far with apomorphine injections. And there are some adverse effects, which I'm not going to go into in the moment, because I want to tell you a little bit about the second drug, which is actually new, and new even to Dr. Fasano, because it wasn't available until lately. And it's a sublingual version of it. Right? So instead of the injection, there's a film. You can see there's a 10 milligram, 15, 20, 25, and 30 milligram film. You'd still have to do the same titration, but because it's not as nauseating and it also doesn't produce as much hypotension, the current recommendations, anyway, are that you don't necessarily need to do this in the lab. Those of us that have just started doing this, I'm still bringing patients into the lab to do this, just so that I'm sure as to what's happening. But in-home titration is possible with this particular sublingual film. The negative of it, of course, anything that doesn't cause side effects also potentially is not as good, right? And so it's not that it's not as good, but it doesn't work as fast. It takes time, because it has to. You have to keep that thing under your tongue for at least 3 minutes. You have to make sure that you don't, move it around into the top of the mouth. It causes some ulceration in the mouth. So lots of potentially oral issues are there. Not sure how easy it is for somebody to keep that, and it doesn't necessarily taste good. So all of those issues are there. Injection works quickly, but then it has to be put on this one. Plus, actually, it's not that easy to get the darn thing out of because, all of us have that experience of trying to get a Band-Aid out of and by the time you get the Band-Aid out, your bleeding has stopped. So you don't really even, it's the same kind of thing. So you got to be careful to get the strip out. So one trick is that if you know you're going out and you're experiencing potentially off there, open one of the 2 of the strips and keep them in your pocket partially open. So if you're off, you can just peel it off and do that, right? And so you can get you can see at the bottom the films like that, right? So a variety of different. You can see it's kind of complicated they're not trivial to open. I've shown a picture, and that's how it goes under the tongue. Works in about 20 minutes. So and you can see that it works. And you have to have, for any talk like this, you have to have some random graphs which show things up and down and statistics, right? Because otherwise, p-values, meaningless stuff, but we have to make it look smart. And so there you go. So change from pre and post dose from Lancet Neurology in 2020. Bottom line is that it also works. Right? And so you can see between placebo and apomorphine, there's a benefit there. And the same thing here. It takes time, though. right? So this graph actually is more important than anything else. You can see that this is compared to levodopa. So levodopa is the blue, and it takes about the same time, whereas the injectable apomorphine will be up and down by the time the sublingual film is working. It'll be finished by that time. So rapidity. So it's a different timeline of these two things, right? And yeah, so are we doing or? 5 minutes. Okay, good. So, I mean, I've got, 48 more slides, but anyway. So, no, I'm just joking. But I do actually. But that was because I just put things together and lots of. So, tremor at the moment is the reason I wanted to focus on that just on one slide is that this is a very difficult. Despite, we're talking about stem cell transplant, antisense oligonucleotides, which you can't treat tremor, Parkinson's disease very well. I mean, so. You got to get clinical equipoise, R.S. Olson's words, right? You got to remember that, we can send William Shatner into space, but we still have, some basic problems of food and hunger on the planet. So we have to be careful as to how much we spend $100 million on viral therapy. Well, we can't treat tremor yet, right? And so we've developed, in our lab, we've been very successful in using injections of botulinum toxin. And in fact, we just got a paper published in one of our flagship journals called Neurology that showed that after injection, and this was actually in collaboration with a friend of mine in Toronto, unlike Alfonso, Robert Chen, who has been instrumental in helping us develop some techniques in our lab. And we showed that after injection of botulinum toxin into patients with tremor, it actually changes the excitability of the brain networks, which is very cool, actually. Something that I know very little about, but managed to learn enough to be able to do this work. And so we've been using this quite successfully in patients that have tremor. It has problems. It's a muscle weakening agent. If you don't get it right, sometimes it can produce weakness, and you have to be careful. It's like anything else in medicine. If it doesn't produce side effects, it's most likely a placebo, right? And so this is not a placebo, and we now have a very successful tremor clinic. Every month we have about 50 patients we're treating for essential tremor and Parkinson's disease. And it's that work that has thankfully led to a couple of the companies now starting their phase 2-3 studies of using toxin back again. This is not my original work in terms of people had tried this before, but it had failed because of weakness. Not that it didn't treat tremor, but At the moment, it's not covered, and so you would have to pay for the toxin itself. The injection is covered, of course, but and we have developed some nifty technology which is being used by a couple of these companies to record the tremor. So we've got the sensors that we use to record the tremor, and the tremor quantitatively then tells the machine, the algorithms that we've developed, which are learning machine algorithms, tell us how much toxin to use in which muscle, and we inject that. And so anyway, it works in about 75% of our patients. And then, of course, it doesn't treat anything else. In Parkinson's disease, you still need treatment. But for essential tremor, it's been a boon. Right? Cognition, right? And so I think we've moved from the hi-fi to, the basic things. And so in the next couple of slides, I just want to summarize that, right? So cognition is very important, and whatever things such as, dance therapy or music therapy or boxing therapy, who knows what it does, but I think it's a great thing to do. Right? And so even though we don't have any idea from the true, here we are, as I said, talking about retroviral vectors into the brain and the science behind that molecular targeting and the mechanisms to this kind of intervention. But I think these things are critical in management of our patients. And while we spend, $2 billion in developing techniques that burn holes in people's brains, we have zero money that's being spent into any of these things, right? So I don't have access for most of our patients, as Shelley will tell you, and all the people that are working so hard to get these kinds of things, such as prevention of obvious things, treatment of mood and nutrition and interaction and speech therapy. These are the kinds of things that have $500, and then we spend $500 million on a virus that's not going to work anyway, right? And so this is the kind of thing we have to be very careful about in terms of how we spend our dollars. And I wanted to just highlight these to, again, bring back that equipoise that we are finally clinicians and physicians and caregivers taking care of real disease and real people, right? Not, and so we have drugs, neither of them really work in Parkinson's disease, but we do use them. Rivastigmine or Exelon, both patch version and oral version we use for treatment. I use it regularly in our patients. The data is, but that's what we got at the moment until maybe our Ambroxol study shows that cognition is helped by Ambroxol, maybe. We've been, there's a wonderful paper that one of my fellows published, two of my fellows, actually three of my fellows, Jackie, Adi, and Soumya, in using this non-invasive transcranial stimulation. I'm a skeptic about this thing. We have a huge investment in my lab doing these transcranial stimulations. We've got every particular disease, dystonia, Huntington disease, Parkinson's disease, ataxia. We've recruited many patients with in the last 3 years using this transcranial stimulation technique. We've developed this technique in our lab using something called TPCS, transcranial pulsed current stimulation. It's a device we've built, and now we're getting somebody to make them for us. Idea being that can we use it for cognition? It's non-invasive. But again, the placebo effect in these interventions is very high. So unless we can actually demonstrate, there's a science behind it, there's a mathematics behind it, which is very strong. But unless we can demonstrate again, we'll see how it goes. We've got a few more years of this that we're going to, before we, the first data set is almost ready. And statistical significance and doing epidemiology kind of work on this thing is useless if it doesn't actually show real world changes. So we can numbers mean nothing. As a mathematician, I can tell you that, but it only means something if it actually produces real benefit. I'm waiting for that yet. We'll see. But at least it's non-invasive. It's easy to do. It just sponges on the head. Well, not just sponges on the head. You connect it to something, but it's along with that. Right? And so and then a couple of other things. If tell me to stop. Because finish this one? Perfect. And that's good, because actually it's a good segue into the last slide, because orthostatic hypotension is a huge issue in patients with Parkinson's disease, and in fact has implications for all kinds of function. You can imagine that if your blood pressure drops, mind fog to fall risk are all big things in patients with Parkinson's disease and in Parkinsonism in general. Recently, and I've become quite taken by this data of this transient orthostatic hypotension. What does that mean? That means that our traditional way, and we teach this, have for years, and has, not my invention, everybody has taught this, is that you measure orthostasis by having the person lie down, take their blood pressure, stand up, 3 minutes later, take their blood pressure, and if you see a drop, that means bad. If it drops by 20 millimeters systolic, 10 millimeters diastolic, and the patient is symptomatic, feeling dizzy, that's a bad thing. However, I took away that graph, and I think we'll stop with this slide anyway, is that latest data shows, and that's in one of my recent papers, looking at beat-to-beat variability. What does that mean? That means in the autonomic nervous system, 3 minutes is too long to wait. In fact, what we've shown, and others have shown actually, not my work, we just reviewed the papers, showed that if you were to do this beat-to-beat measurement, within the first 15 seconds, blood pressure drops substantially. And it might actually rebound, drop again, and rebound. So by the time 3 minutes go by, and we in fact in the lab we've invested in 2 of these beat-to-beat measurement machines now, and I'm doing it on every patient that has any mental fog or that kind of thing, and we're finding that in fact this trajectory of very rapid fluctuation of blood pressure may in fact be more of a risk factor for fall, because you stand up and it's in that first 15 seconds, 30 seconds that you feel this hypotension occur, and that's when you fall, right? Transient severe lightheadedness, blurring of vision, and there's interesting literature on this. And so now every PD patient in that we're seeing that has any symptoms of mild cognitive impairment, these kind of things, and there's a lot of data showing that this brain fog that patients feel can actually be, and I've actually started treating patients with abdominal binders, which one of my recent PhD students did work on this, and in fact oral medications to see if we can get the blood pressure up. Right? So this idea of keeping blood pressure low and cardiovascular risk, et cetera, doesn't work. Those ideas are not correct over here. And so this is important. I don't know if I have, actually don't have. So what do I do? Well, we do, things such as the abdominal binders, domperidone, not particularly great in treating this. And I use midodrine, fludrocortisone, increasing water consumption, which you have to be careful, of course, in Parkinson patients with respect to having more requirement to go pee. Right? And so, so I think I'll stop there, and we'll leave the other 285 slides for the next time. So thank you very much.